As people are filtering in, I want to just welcome everybody to this week's Business Unusual. I, along with my co-host Peter Klein, we decided to do this webinar right when the COVID lockdown happened, because we knew that business folks were going to have an unusual time. We knew that that we were going to want clarity. In an election year in the media, you can't always get straight shooters and honest opinions. So what we've done every week is had leaders in every industry who are not only recognized experts, but certainly straight shooters who are going to give us answers and guidance as we continue to try and find our way through this very, very unusual and scary times. Our guest this week is going to be is Dr. Ken Kashansky. He's the Dean of the School of Medicine and Senior Vice President of Health Sciences at Stony Brook University. And I've known Dr. Kashansky for a long time. I've been very involved with Stony Brook, was very excited when he joined us, and he has a distinct reputation, not just at the university, but certainly nationwide, as not just being an expert, but a straight shooter. And Ken, we wanna certainly welcome you. And I want to tell you, so I'm a Marine, I served, and every time somebody hears a Marine, they say, thank you for your service. And I want to start the show off by saying, you know, thank you for your service, and thank you to all of your troops for their hard work and their service. You know, maybe we can start with you just sort of giving us the 30,000-foot view of sort of what we all went through, right, from the trenches. What did we all experience? What did we all go through?
So there are all sorts of military metaphors one could use to describe the journey that we all took. Our journey at Stony Brook University began, the first event was our first person under investigation, PUI as they're termed. An individual who comes in with an influenza-like illness. We had heard about this disease called COVID-19 caused by this novel coronavirus, and we were on alert. And our first patient, who we termed a PUI, came into the Stony Brook University Hospital emergency room on February 8th. Turned out not to have COVID-19, probably had influenza. Over that month, over February, we were watching a lot of people. The testing, if you remember in those days, was spotty. Maybe it was accurate, maybe it wasn't accurate, but by March 8th, we had our first documented patient with COVID-19 who came in through our emergency room. And from March 8th, for the next 5 weeks, our census of COVID-19 patients grew from 1 to 437 at its peak. And so that's a rather rapid acceleration of admitted patients. Of course, probably 2/3 of the patients who came to the emergency room who turned out to be positive for COVID-19 were not ill enough to be admitted to the hospital. We sent them home, obviously quarantining at home, with medications to help with the symptoms, with the advice to come back, you know, if your shortness of breath gets worse, if your cough gets worse, if your fever gets high. But overall, about 1/3 of the patients who presented to our emergency room with those symptoms ended up in our hospital. At the peak, we had well over 130, maybe 140 patients in the intensive care unit, which is more than double our normal intensive care unit census. We have a capacity for taking care of 65 adults in our intensive care units, and we had well over 130, probably close to 140 patients. During that time, during that ramp up, again, using some military metaphors, we were really mobilizing. We were mobilizing our facilities, we were mobilizing our people, and we were mobilizing our readiness to care for this presumed large number of people who are going to be coming into the hospital.
Hey, Ken, let me just ask you a question. Did you
Sure.
did you know what was coming? Were you scared, or were you surprised by all of this occurring?
We were about 5 to 7 days behind where they were in Manhattan. So we did have the advantage, the slight advantage of watching the rate of rise of patients who are contracting this illness. We thought that we had heard from China and from other countries, from Europe, that crowding and close proximity of people was a huge contributor to community spread of the illness. We thought we were going to be somewhat protected out here in Suffolk County. Au contraire. Suffolk County attack rate was just every bit as high as New York City. And so our proportion of patients who came in was the same as we saw across the 5 boroughs.
But yet in other states,
yes?
I'm sorry, I was going to say that in other states, we haven't had that kind of impact. I mean, I'm surprised that New York was hit so hard.
So we were hit hard. Now, of course, we know that Florida just passed New York in total number of cases, even though we're about the same size state. California, of course, Texas, those numbers are going up. But the biggest difference between New York and these other states is the mortality rate. The mortality rate in the state of New York has varied by institution. I am actually very proud to say that the mortality rate within our hospital system, Stony Brook University Hospital, Southampton Hospital, Eastern Long Island Hospital, that our mortality rate has been lower than what's been reported in other healthcare systems on Long Island. So there's been a variable mortality rate across different hospital systems, but overall for the state of New York, it has been higher. Whether that is we have more of the confounding risk factors, overcrowding. We know that people of color are disproportionately both come down with the virus and it's worse. We know that there are all sorts of social determinants of health that contribute to that. It's conceivable there are other factors, genetic factors afoot that might be contributing, but we do know that we have a number of people who are at high risk. There were, of course, a large number of people who succumbed to COVID, who were elderly, who were in nursing homes. We actually oversee a nursing home here at Stony Brook, and we had mortality in our nursing home. So a lot of variables, and in retrospect, in a couple of years, we'll probably figure it all out. But right now, all we can say is we were hit very hard. But right now, we can also say New York is probably one of the safest places in the country, vis-a-vis, you know, the expanding attack rate and test positivity rates of anywhere in the country.
Yeah, and I think, you know, it's confounding, right? The disparity of the death rate. But like to the extent, and you know, politics aside, it's the healthcare professionals that I think are learning from each other. And the same way I think you guys had a 5 to 7 day head start to see what was going on in New York City, these other states, you know, got to learn a whole lot of intel from you guys who got hit at Normandy on the first wave, right? I mean, that's really what happened.
Let me give you an example that speaks to that point exactly, about how if you are clever and insightful and can learn from others and then learn yourselves by investigating. Remember, we're unlike a lot of hospitals, we're an academic medical center. We have a medical school here, which means we have a lot of faculty who are very interested in learning and understanding and exploring the origins of disease. And so let me give you one example where our investigation greatly reduced mortality rates. So we had learned from our colleagues in Europe early on, just as our epidemic was taking shape, we had heard from colleagues in Europe that blood clotting was becoming a problem in the patients with COVID-19. That particularly piqued my interest because I am a hematologist by training. And one of the areas that I am medically expert at is blood coagulation and blood clotting. So when I heard that a lot of the people in Italy and in Europe and the rest of Europe were having troubles with blood clotting, we had a keen interest in understanding it and seeing if there was anything we could do about it. And early on, as the number of intensive care unit patients was rising, two of our intensive care units decided to go after that blood clotting problem with very aggressive measures. Anticoagulation, thinning the blood to prevent the blood clotting that many people, including us, felt was contributing to this very high death rate. Other intensive care units here at Stony Brook acted sort of as controls. We used the standard of care. If you developed a blood clot in your leg, if you developed a blood clot in your lung, we would use full dose anticoagulation, just like we normally would in patients with pneumonia, normal pneumonia, what a strange concept that is. But you know, the run-of-the-mill influenza or pneumococcal pneumonia, people with heart failure, we would anticoagulate them if they had blood clots. So we had a group of patients who were just as sick, who were getting very aggressive blood thinning, and we had our standard of care patients. What we did was we measured every day, we measured a marker of blood clotting. It's called a D-dimer test. And once the D-dimer test got high enough, we would just anticoagulate the patient. We would not wait to see if they had a big blood clot in their leg, a big blood clot in their lungs. After about 200 patients, we now have data from about 100 who were aggressively anticoagulated and about 100 who were treated standard of care. The mortality rate in the standard of care ICU patients was more than double that of the mortality rate of the patients who had that more aggressive D-dimer driven anticoagulation. And so we learned during this epidemic here at Stony Brook, which now the people in Florida, the people in Texas, the people in California, Arizona can learn from our experience and help them be more aggressive about getting on top of the blood clotting problem, and by so doing, hopefully reduce the mortality.
Yeah, that's really a great story and really great service that you and all of your fellow healthcare professionals help provide to the state. So I want to ask a question. You know, I spend my days talking to business owners. That's who I've represented over the years. And the question and confusion that has always existed and continues to exist is, we know that masks and social distancing work. We know that. We've seen New York get incredibly healthy because of masks and social distancing. And the confusion is, if they work, then why the need for any more restrictions other than people need to be wearing masks and be socially distanced? So with the schools being reopened, with businesses being reopened, with sporting events, with all these things where people are really hurting, right? There's a lot of confusion. And so people blame it on politics and people blame it on this. But I want to hear from a science perspective, if you can, Ken, what is your scientific opinion on that?
Great question. If every individual had one of these, this is called an N95 mask. I'm sure people have read about them in the literature and in the newspapers and heard about them. This is the mask that filters out, and then 95 refers to, it filters out 95% of the droplets that could carry the virus from me to you or from you to me. Now, 95% is not 100%. And so if you have a person who's very infectious, frequently not symptomatic, doesn't know she or he is infectious, Filtering out 95% is pretty good, but it's not filtering out 100%. If you only have a standard surgical mask or a bandana or, you know, something that is much less effective at filtering out the particles, you still have some risk. So that's point number one, is no droplet preventive measure is 100% effective. Best we have in the field, 95%. Number two, there are, of course, people who don't adhere to masks and social distancing. Social distancing, 6 feet. We know that the majority of potentially infectious particles, if you're sneezing or coughing or singing or speaking loudly or whatever creates droplets, any of those people have studied how far the droplets will travel, a standard droplet from an individual coughing or sneezing, and most of them drop because of gravity out by 6 feet distance. That's not absolute also. Conceivably, there are particles that go farther and could theoretically infect at 8 or 10 feet out. Again, probability, 90, I don't know what percentage it is, but let's for argument's sake, 95% are dropped to the ground by 6 feet. It's not 100%. So that's another potential way that people can get infected. Even if you take those two precautions, masks and social distancing. So it's not a perfect system, but we do know that it greatly reduces the risk, but not to zero. But we do know it works very, very well. And then there are the people, you know, there's stories now on the news about how all the big stores, they've, you know, opened up the stores and the Lowe's and the Home Depots and the Walmarts, everybody, you know, is open for business now. And all of those companies have been acting responsibly, putting in place, you know, you have to have a mask. If you come in our store, we, you know, and they put arrows on the floor so everyone goes in one direction. Very responsible activities. And then there's the person who says, this is a free country, I don't have to wear a mask, you know, sue me. And I have a problem with that, obviously, as a scientist. So you asked about the science of it. Nothing is perfect in science ever, or medicine especially. And so these devices, masks and social distancing greatly reduce, but do not eliminate completely the risk. And we know that this virus is quite an infectious virus. It's probably not as infectious. I've heard that the most infectious virus is measles. And of course, New York went through that, you know, story a couple of years ago because of falling off rates of immunization. But we do know that it's a highly contagious virus that has developed itself into quite the spreader community.
So it brings up the next sort of point that I think I want to get a good scientific answer on, right? And that is, well, the flu kills people every year, and we don't shut down schools, and we don't shut businesses, and people don't have to get a flu shot. So why is this different?
Au contraire to one of the clauses in there, I would be remiss if I didn't remind people to start getting their flu shots at the appropriate time, because flu shots work, and that's the big difference here. There are preventive measures, immunization measures, flu shots, which are not perfect again, nothing in medicine is, but they will greatly reduce your risk. Moreover, we know that there is some immunity that was imparted from last year's influenza strain that circulated and from 2 years ago influenza strain that circulated, so that we as a population have some innate immunity, some built up immunity to influenza. But this virus, as the word implies, novel coronavirus. We have not seen very much of it. We have other coronaviruses that we all see. It's one of the causes, the common coronaviruses are one of the causes of the common cold, but obviously this is a different animal than the coronaviruses that cause a cold-like symptom for a couple of days. This novel coronavirus has genes in it that we have not seen before, particularly the ones that are important for immunity.
And Doc, do you think that because of that novelness, if you will, can it then mutate unto itself and another novel virus could come around?
Mutation in viruses is state of the realm. That happens a fair bit. The question is, are the critical determinants of immunity and disease-causing genes, are those genes mutating, or is it other parts of the virus that are mutating? The quintessential, in my mind, I'm not an infectious disease expert, as I said, I'm a hematologist. The quintessential virus that mutates so much that we cannot develop a vaccine is HIV, human immunodeficiency virus, AIDS. So that virus, you know, it's been around with us since the early 1980s, nearly 40 years. The epidemic started in 1981, so we're almost 40 years into the AIDS epidemic. Do we have a vaccine? No, we don't. That virus mutates very frequently. And another lesson, while I'm on HIV, another lesson that was very informative and could possibly lead to novel treatments. I trained at the University of Washington, and I was in training when HIV came along, and it came along in Seattle. And so I saw many of the very first patients who developed HIV when I was in training at the University of Washington. Early on, there were a group, probably 3, 4, 5% of people who should have gotten AIDS. They had, you know, they were IV drug abusers who just would not give up sharing needles. There were people with hemophilia who were getting blood products before we had a test to screen blood for HIV. There were men who were having sex with men and were doing unprotected, very unsafe sexual practices. And there was this cohort of people, 5% maybe, who just didn't get AIDS. And we were scratching our heads. These people were exposed hundreds of times to people with HIV, and yet they never got it. About 10 years later, a clever geneticist was looking and found that the 5% of people had an inherent mutation in a gene, their normal gene. It was called a chemokine receptor. And this normal gene binds chemokines, as the term receptor implies. But it was also the receptor, a co-receptor for HIV. The virus couldn't get into the cell unless you had this receptor. And this 5% of the population had a mutant receptor that the virus couldn't use to get in the cell. So you had people who were inherited resistance to HIV. Is there something similar in the human population now that predisposes them to severe COVID-19 or protects them from severe COVID-19? And Stony Brook, along with about 12 other institutions around the New York area, are part of the New York Genome Center. And the New York Genome Center, we're all looking for patients who are unusually susceptible to COVID-19 or seem to be unusually resistant to COVID-19 to see if we can find those differences that might lead to a new way to treat individuals. One of the things that I'm most interested in as a hematology, and I'll get off the hematology bandwagon in a half a second, but as I said earlier, blood clotting is a big problem in COVID-19 illness. So it turns out that there is an inherited difference in how much blood clotting proteins you have in your blood. And it's as simple as your blood type. If you have type O blood, you have about 30% lower level of two particular blood clotting proteins, both of which are vital for blood clotting. If you have type A blood, you have about 10% more of these blood clotting proteins than average. Guess who gets more severe COVID and more frequent COVID? Type A individuals and type O individuals are relatively protected.
Interesting.
So that I'm very proud to say I'm type O blood. But the scientific point is we already are beginning to discover differences in people's susceptibility to the disease based on their levels of blood clotting proteins. And there was a study out of Spain, out of Madrid. There's a big hemophilia clinic in Madrid. Now, as you know, Spain went through a horrific COVID epidemic. It turned out that 20%, 25% of the Spanish population encountered COVID-19, and a big number of those people had pretty severe disease. It turns out that at the hemophilia clinic, people who are having trouble clotting their blood because of, they inherit the genes, very low incidence, like 1.5% of those hemophilia patients developed COVID-19 because they had this defect in blood clotting. So as I have said in some seminars, finally people with hemophilia caught a break.
Hey, do you think baby aspirin, you think a baby aspirin would help that?
So people are now beginning to explore ways to ameliorate the blood clotting. As I said, in the intensive care unit patients, we treated people earlier with more aggressive anticoagulation. So those are the kind of questions now that we should be asking, but importantly, testing in clinical trials. Right now at Stony Brook, we have about 75, in my school, in the Renaissance School of Medicine, we have about 75 scientific studies, including many clinical trials of interventions in understanding the causes and intervening in COVID-19.
Interesting. So I want to turn to a big question on everybody's mind right now, and I think you have a very unique perspective, both as someone who's been on the healthcare lines with COVID and someone who runs a medical school, and that is school opening, right? So I can tell you it's a huge issue. My daughter just graduated college with no graduation. Peter's son just graduated high school and is going to be doing virtual college his first year. All the schools on Long Island, two families have to work here on Long Island. It's a huge issue. And,
Yeah.
And I'm sure, again, from a healthcare perspective and from the dean of a medical school, you have a very unique perspective on this. So what's your take on it, Ken? Because it's big.
So at the risk of wading into the politics of this, because as you know, and all of us know, there's huge politics afoot, and that's very unfortunate. I would go with numbers. I would be very, very cautious. I would love to be able to do frequent testing of individuals. We are working here at Stony Brook University with the exact same questions. Should all of our courses be remote learning? Should we have hybrid courses where you really need that personal interaction between student and teacher? High schools, elementary schools. I don't buy that kids don't get very severe COVID-19, so let's just go with abandon. We need to be cognizant of the environment we're in. Right now in New York, with only 1% of COVID-19 tests coming back positive, and that's true at University Hospital too, most of the COVID testing we do comes back negative. So with low rates, I think it's reasonable to think about restarting some face-to-face or mask-to-mask learning. but we have to monitor carefully. What I hope we will do here at the university is if we have adequate testing facilities, and again, that's an unfortunate, we do not have at our university hospital the capacity, the bandwidth to test every new student who is coming to Stony Brook University. I would love to be able to offer the main campus that, but because of shortages on the testing machines, shortages on the reagents, or, we're doing better on swabs now, but we're running out of reagents. We don't have the machines needed. It's been on back order. We ordered it 4 months ago, this machine that will allow us to do 2,000 tests a day. That's what I'd really like to do. But right now we're, very, very limited in our testing. But as long as you can test, and as long as the rate stays low, it's worth considering with masks and social distancing. But it becomes an issue. Let me illustrate with my school. As you may know, well, Joe, I know you know, we just opened up 2 new facilities, a research and education facility, what we call the MART building, and a 150-bed bed tower. And I'm very proud, we have a 305-seat auditorium, beautiful state-of-the-art auditorium, which would have housed all of our medical and dental students in a lecture format. When we calculate how many people can safely fit into that auditorium with 6-foot social distancing, 56. That's all we can get in our 305-seat auditorium is 56 individuals safely, socially distanced. So facilities become an issue for colleges and universities. And so that's another consideration in the grand equation about opening schools to students. How do you put at social distance an elementary class of 25 or 30 in a classroom that was built for 25 or 30 students and now put them all 6 feet apart?
And while you agree that, and I'll agree with you that the testing is a critical part of this, it's not a panacea, right? Because you could test everybody and everybody, negative, but then they get it and you don't know they're getting it and they're spreading it. So, I mean, the testing onto itself is not the answer, right?
Well, testing once, you're absolutely correct. If you screen everybody who arrives from Poughkeepsie or from New York City or from New Jersey to Stony Brook University and only test them upon entry, you're absolutely right. They're going to go out to Stony Brook Village and possibly get it, et cetera. So you have to do reasonably frequent testing, and you have to be ready when someone starts developing symptoms to test them on the spot, get the result back in a day, and then keep the people who they've been in contact with, contact tracing.
The tracing. Let me ask you about that, though, because I was wondering, because we don't have a rapid test available at home, right? So what we've been doing is just monitoring temperature, and there's like a thing I bought, it was very inexpensive, like an oximeter or something, where you put your finger into this little meter, yep, and it tells you your oxygen levels. Is that good? Is that good form? Is that a good idea to sort of monitor that?
It's called a pulse oximeter, and what it does is it measures the saturation of oxygen in your blood. Someone who is healthy, who has healthy lungs, the saturation is usually in the arterial blood about 97, 98, 99% of the possible amount of oxygen that could be in that blood is in that blood. Smokers, it's going to be lower because they have lung disease. People with heart failure, it's going to be lower because they have heart disease and fluid is backing up in their lungs, et cetera, et cetera. So if you're otherwise healthy and you have your baseline level of 98, hopefully mine's 98, I haven't tested myself, and you begin to develop the early signs of the pneumonia that is the first portal of entry for this virus, your oxygen level is going to start to fall. And whether you might pick up the fact that you're developing this pneumonia a day earlier by watching the pulse oximeter go down versus just starting to cough, having a fever, feeling short of breath. I don't know, to be honest, whether the pulse oximeter will pick it up a day earlier
I see.
than the development of the symptoms of the pneumonia or the, the shortness of breath, the coughing, etc. But it certainly doesn't hurt. And seeing, it's a completely non-invasive test.
Sure,
It's not
it's easy.
puncturing your skin or anything like that. It's good for the economy, at least for the companies that make pulse oximeters, because we're talking about business here. And it's good for testing because it'll drive people, even if it's a false positive, it'll
Right.
drive people to get another COVID-19.
It seems to me like a lot of this is personal responsibility and wearing a mask. I mean, if you do those two things, monitor yourself, be aware, be empathetic to other people, I think we could lick this thing and get it over with.
That's you hit the nail on the head there. N95 mask protects me and protects you. The vast majority of and as you know, we're incredibly short supply of N95 masks, which is a shame in and of itself. I think I've used 2 or 3 in the last 4 months. When I go on rounds, I use it, and things like that. But for routine use, I use a routine surgical mask, which are much, much more readily available. The masks are not going to protect you. They're going to protect the person you're speaking to or the person you're coming in contact with. So it's being sensitive to others. If you don't wear a mask, you are endangering others. You're not necessarily endangering yourself, because if all the people you come in contact with have masks on, you're being protected from them.
Right.
You protecting them from you.
Let me ask a question, Ken, because again, we're getting some questions on this, and this is where I hear a lot of grumbling, right? Because there's a lot of grumbling in the business community, and there's a lot of pain, particularly in the restaurant sector. Okay, so 6-foot social distancing and a mask. So let's see if we're on the same page here. The most protection we could have right now, layman, is 6-foot social distancing while wearing a mask. Some normal surgical cloth mask.
Yep.
Okay. If you're outdoors and you're more than 6 feet away, you're okay. No mask. Everybody seems to be okay with that guideline. The issue is indoors, right? If you can be 6 feet indoors away, is a mask needed or isn't a mask needed, right? And then it comes down to restaurants.
Yeah.
The patrons are sitting there without masks. The servers have masks on, and the patrons are not 6 feet away. And so none of this all sort of makes sense. And is it just that we're doing the best we can with what we have, or is there a rhyme or reason to this sort of weirdness?
So a couple of observations on restaurants. First, I was in Manhattan over the weekend, just wanted to see what it was like. I was wearing my N95 mask. And it's now coming to resemble a little bit like Paris. It's all the sidewalk cafes. They're taking up all the parking spaces and putting tables and tents. And you remember that old movie, that Dustin Hoffman movie, The Graduate, right? And the key, the takeaway line from that movie is
plastics.
I've got one word for you: plastics. And that's the word that characterizes all these sidewalk cafes in Manhattan. They're putting plexiglass between. That's another business that we should have all invested in early. They're putting up plexiglass shields between tables, right? You got the 6 feet, you got the mask, you're protecting from the other people, right, who may not have masks because they're drinking or they're eating at the time. Okay, so plexiglass is an additional level that the restaurants can use to help with the crowding issue. The next issue with restaurants is we've been talking a lot about droplets and inhaling droplets from somebody who is speaking to you within 6 feet, maybe within 8 feet, but within 6 feet, because you or they don't have masks on. Well, the droplets, as I said earlier, settle to the ground, but they also settle to the restaurant table, and they settle to the restaurant chairs, and they settle to the restaurant glasses. And so contact with the table or with the glass or with the silverware or things like that could conceivably, if you now take your hand that was contaminated on the table and put it in your mouth or put it in your nose, etc. One of the, I've actually heard this and it makes sense to me. There's not a rigorous randomized controlled trial here, but it makes sense. One of the big virtues of wearing a mask is it reminds you not to put your hand in your mouth, put your hand on your nose, and bring the virus from the table surface into your upper airway, because you're wearing this thing and it's not terribly comfortable, and it's a constant reminder that you got to keep your hands away from your mouth and your nose. So that's another way that restaurants pose a slight risk. I did eat on one of those sidewalk cafes when I was in the city, so I'm not completely fearful of it because they took the precautions. They had the plexiglass. I was with my wife, who obviously I'm not afraid of my wife most times. Just kidding, just kidding. And so there's a lot of precautions, but again, the science is nothing is absolute. There's no 100%. Even a vaccine, as we all know, with influenza, yes, some people get bona fide influenza even when they took the flu shot. And so we are waiting for a highly effective vaccine. And of course, there's a lot of progress on, you hear it in the news. That's another business story also.
Yeah, and so I think that being restaurants have been open, I think that we're learning a lot of data, right? We're learning a lot of data about this virus, because in New York, we didn't see a spike when the restaurants reopened. And so I think that's all good data. And I want to talk about a vaccine before we run out of time. Pfizer is working very, very hard, and they've contracted with the federal government, and they're exceeding expectations at this point. And I guess in listening to you, here's sort of how I am coming out on it, right? And I want you to weigh in on this and then talk about the vaccine. But it's to the people who are always saying, well, we have the flu and we don't shut down businesses, and well, I have the right to make my decisions. What I think I'm coming down on this now is, when we are comfortable that our healthcare facilities have the right infrastructure, the right training and knowledge, and when we feel comfortable that there is a vaccine so that the government can feel it's giving people a fighting chance to protect themselves, right? Then we will feel more comfortable with restrictions, loosening restrictions, and allowing people to have a little bit more freedom in their decision-making processes. You agree with those premises?
I do. It will be very dependent on how effective the vaccine is at evoking protective immunity. That's the phrase, that's the buzzwords. Protective immunity. And that's the big question right now. We know that a couple of the vaccines that have been tested in people are, number one, safe, important, very, very important. And we know that they are evoking some antibodies against some of the proteins in the virus, because that's how they were designed. Whether those antibodies are protective or not is what we don't know yet. And it's going to take a lot of patients, a lot of people, 30,000 is what we're hearing now to mount a clinical trial. And this is also something that's fascinating. How do you test? Do you vaccinate 30,000 people and let them go about their business, mask, social distancing, in New York that has a test positive rate of 1%, it's going to take quite a while to be able to show that those 30,000 people come down with COVID less frequently or not at all than 30,000 other people who you never vaccinated, who are in the same city, doing the same things, doing the same masks and, you know, protective measures. It's going to take a long time to figure that out. Or do you vaccinate and expose the individual to virus? Basically, give them the virus. You'll know a whole lot faster. And this is where the bioethicists need to weigh in. I mean, it was very interesting. My daughter is a malariologist. And of course, there's another organism where people are desperate to develop a safe and effective vaccine because, you know, you can get malaria over and over and over again. So people are not particularly good at developing immunity to malaria. Can a vaccine do better? And so in malaria vaccine trials, daughter pointed out, by the way, daughter has a name, I call her daughter. Her name is Alexis Kashansky. And daughter has pointed out to me that in the malaria vaccine field, they do expose people to malaria, to mosquitoes that are carrying malaria in the testing phase. Let me go back to one final point about the difference between influenza and COVID-19, and that's the mortality rate. They are sizably different. The mortality rate in influenza is about 0.1%. In COVID-19, it's about 1%. That's where the numbers are kind of settling out. Obviously, there's variation based on age and lung disease and diabetes and all the other risk factors. But overall, as the population as a whole, it's 10 times higher. It's still only 1% overall, but it's 10 times higher. And a sizable number of people are already immune, and hopefully 60, 70, 80% of people get flu shots. So that's, I think, the two major differences between influenza and COVID-19 is the fact that influenza has been around a long time and a lot of us have immunity or partial immunity, and there's a way to boost your immunity every year as opposed to COVID, which has a 10% higher mortality rate.
So I want to ask you two questions that that I think might be, you know, your best guesses. One is hindsight, right? Hindsight is certainly 2020. You know, do you feel that we overreacted or underreacted in sort of from a scientific perspective to this? And then what do you think a realistic timeline is following the science and your experiences, right? Until you and the science community would feel comfortable that we're not at high risk for this terrible thing.
So there's two ways to get to, I'll answer the latter question first. There's two ways to get to not at risk of SARS-CoV-2, the virus that causes COVID-19. One is called herd immunity. That is such a sizable fraction of the population is naturally immune because they've seen the virus, is naturally immune to the virus that the likelihood that someone who is spewing virus encounters a person who's not immune is low. And so the virus doesn't spread in the community because most of the people you come in contact with have already had it and they're immune to it. So the disease doesn't spread and the disease extinguishes itself. That's the theory behind herd immunity. Now, herd immunity works only when 50, 60, 70, 80% of the population are immune. We don't yet know if that's even possible with COVID-19 because we don't know if the immunity lasts. It's very possible you get COVID-19, you recover from COVID-19, which tells you your immune system kicked in and got rid of the virus, but we don't yet know if that's lifelong immunity like it is, with mumps and measles. We don't know if it's immunity that lasts 4 months and then you're susceptible again, like in malaria, which you can keep getting over and over again. So there's herd immunity and then there's the vaccine, right? And if we can successfully get an effective vaccine, that's when I think we are going to feel a lot more comfortable about heading back towards normal. As I said, towards normal, I don't think we're going to go all the way back to the way we were, at the beginning of the calendar year. There's going to be changes, working from home issues, all the rest. Did we overreact or underreact at the beginning of this? The retrospectoscope, as you say, is perfect. I think we probably delayed in New York, we probably delayed about a week longer than we would have otherwise, but I'm not putting any blame on the governor or the mayor, anybody like that, because there were a lot of examples out there. Look at what's now called COVID-1, the SARS infection from 2003. That never got anywhere near us. It affected Toronto, it affected some cities in the east, but it was not a world pandemic. And this virus, of course, was supposed to be like that virus. And so I can see how decision makers, could have said, well, let's wait it out a little bit. But
it's hard to know.
It's very hard to know. Do we wish we had shut things down a week earlier? Of course we do. Because
Doc,
the says we would have saved 30,000 people's lives.
I want to thank you for your indefatigable efforts and your team, but let the listeners understand that you're also the dean of the medical school. And I wonder, what impact does COVID have on the cohort of new doctors coming out and the impact that you have as as part of the administration to teach these young doctors? It's a lot going on there.
That is the understatement of this this discussion. There is a lot going on. Our medical school is a very fine medical school at baseline. Early on in the epidemic, I sent out a number of communications to our faculty, our staff, our students, keeping people abreast of where we were. But I also usually finished the communication with how we respond here and how we respond now will define us. And I think I'm very, very proud to say we stepped up here at Stony Brook. Specifically, I'll give you a perfect example, the medical students. So we were able, because of the way our curriculum works, we were able to allow our senior medical students to graduate early, almost 2 months early. We graduated them with a virtual ceremony. I think it was April 8th. Normally, they graduate near the end of May. And then we asked for volunteers to sign up to work in Stony Brook University Hospital as assisting physicians. They had their MD degree. They were not yet licensed physicians, but neither are interns. And so they were very equivalent to bringing on a cohort of about 50 interns into University Hospital just as the peak in COVID infectivity in Suffolk County was hitting its maximum. And I will be honest, a lot of the people in our hospital, there was a little trepidation, well, last week there were medical students, how much can they really help? Man, did they step up and help, so that 2 months later, when it was time for them to go and do their real internship, there was such a lament. Oh my God, what are we going to do now? They helped us so much. It was very heartwarming for me as the dean of the school. They learned, because we were communicating, I was getting all sorts of messages and emails from our medical students, and they were just so heartwarming about their lessons and their life lessons learned, because every hospital had a lot of death. You know, on a 12-hour shift, some of our nurses, physicians, students were seeing 3 people pass away on one shift from COVID-19. And that is the health, you know, that's the health system that had the lowest mortality rate on Long Island. So there was a lot of life lesson, there was a lot of empathy, there was a lot of team building from this lesson. Nobody can get out from this epidemic without realizing that medicine is a team sport, and that every member of the team has to step up, because if the respiratory therapist doesn't step up, or the dietary people don't step up, the nurses, the ICU people, the physicians, if everybody is not clicking on all cylinders, we are not going to be successful in getting through this epidemic as best as we possibly can.
Yep.
And
Ken, I'll say that I agree with you that, you know, people, I don't blame anybody. People
Nor
did
do
their
I.
best. People did their best, right? I mean, we here in New York, the fear we felt on 9/11 for a day, we were feeling for 2 months, you know, through March and April, incrementally growing. I will never forget that feeling that we just had, and people were trying to do their best. You know, what I try and explain to people is it's just unfortunate that it happened to be a presidential election year, because I think it complicated the issue even further. But I do think everybody has done their best and continues to do their best, and we just have to keep trying to push forward. You know, I do want to thank you. I know you're busy, so we'll come to an end. I do want to thank you and your team, but I do want you to have the last word and have a positive word, right? So our business folks are, we talked about it earlier. We're all kind of stuck in the mud. They're a deer in the headlights. So give us some hope. Give us some hope here.
so obviously I'm an oozing academic and I'm an oozing scientist, and I really believe in the scientific method and using the science to our personal advantage. I agree with the comment. I don't blame anybody in the state of New York not having, but I'll leave it at our state borders. The hope is that the scientific process will predominate and we will win the battle. I actually have a lot of confidence that we will win the battle. Will it take, you know, 8 months, or will it take 18 months? I don't know, because I can't predict whether the vaccines are going to be successful the first round or the second round or the third round of vaccines. One thing and this is a business point, in the pharmaceutical industry, as you probably know, only about 10% of the drugs that on paper, that in the laboratory, that in animal studies, and that in the very first in-human studies, all look promising, still 90% of them fail to make it to market, because they fail in those critical large human trials to either truly be safe or truly be effective. I have to judge this potential success of a vaccine against that track record, that, you know, any given drug, presumably any given vaccine, might come across a point where you say, well, this one's not going to work. We got to go back and try number 2 or try number 3. And to the extent that the government has helped support and industry has helped support parallel pathways, not serial pathways, 10 different companies trying to get a vaccine all at the same time, it would seem inefficient. But in this particular case, it's a necessary inefficiency. And so I balance the likelihood that, you know, 90% of drugs ultimately fail to get into the marketplace against the fact that we're throwing 10 different vaccines up there. And, you know, as they say, hopefully one will stick.
That's great. I want to thank you again for joining us, and for our viewers. Next week we have Jay Oliver, who hosts the morning show on Long Island News Radio. Jay has interviewed hundreds and hundreds of people all throughout COVID, and we're going to get his take on things as well. Just keep up the good work. Really, you make us all very, very proud. We're so proud to be you know, under your care and your watch and your team. And
Stony Brook. Let's not forget Stony Brook.
Yeah. Well, Peter and I are Stony Brook grads too, so that's a good.
Yeah.
That's another
Excellent.
good.
Good to hear.
Yep. So Ken, thanks
Doc.
for your time. Very, very helpful. Thank you.
God bless.
Pleasure. Have a good day, everybody.